Okay, we're going to talk about cranial nerves and what they do. And that's pretty much it. And that's the end of this portion of the class after we talk about that. So let's take a look really quickly. Yeah, there we go. So here are our cranial nerves. This is where they come from. Basically, we're going to run through a bunch of different pictures, and I'm going to try to give you some mnemonic devices on how to remember these, because you'll need to know most of them. So they're numbered. In fact, they're numbered in Roman numerals, which is going to make it even harder for some of you if you don't know your Roman numerals. Not my choice. This is just how they're numbered. So we've got some issues with these numbering systems, which we'll talk about. So we have the first nerve, which is the olfactory bulb, and then the second, which is optic, and all the way down. One of the main problems is we also have this other nerve here, the terminal nerve. So what are you going to call it? 0? I guess that's why they've gone with terminal nerve, and it's where I've put these two little blue lines right here. It is likely active for pheromone sensing, but like we talked about in class, how active actually is it? I mean, how readily do we actually respond to pheromones? Not very well. So it's there, but there's a big question about, how there is it? Like, what does it actually do? Does it do anything for us, or is it just kind of sitting there and we don't even really process the information that it gets? Or does it actually process a lot of information? We just haven't made sense of it yet. Unsure. There's still a lot of studies being done with our ability to sense pheromones. And overall, it doesn't look good for pheromones, but there are some interesting things. More like smells you get used to, or pheromones you get used to, might work, but that might be something that happens with the olfactory bulb. Who knows? Anyway, there's a terminal nerve. Its name is terminal nerve. It doesn't have a number. Okay, so then you've got 1, 2, 3, and 4. And once you hit 5, now you're talking about ones that are important for speech and hearing. So 5 through 12 are important for speech and hearing, with the exception of 6. 6 is actually not important for speech and hearing. So the ones that you really need to know are trigeminal, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and hypoglossal. Now, if you have had a biology class, some of these might make sense what they are doing. It might make sense that they're speech and hearing nerves, right? So facial, that one, you don't even have to have had a previous class. You know that facial is your face. So that's a nerve that makes sense. Vestibulocochlear, that's the ear, right? So it makes sense that that's going to be important for speech and hearing. Glossopharyngeal, well, the pharynx, and then the tongue is the glossus. So we've got, that. So it's tongue and the pharynx. Vagus probably doesn't mean anything to you yet. Accessory doesn't mean anything at any point. I mean, that's a horrible name for a nerve. And then hypoglossal, again, we've got tongue again. So you can kind of see why these might be important. Okay, so let's move to this picture so we can actually talk about what these things do. Let me orient you to what you're looking at here. The connections, so these red and blue lines, these are the type of connection that each nerve is making to where it goes. So to the eye, to the lungs, to whatever. It's either a motor connection or a sensory connection. A motor connection is blue, a sensory connection is red, and sometimes it's going to have both, but not all of them. And this is something that we need to know as well. So we'll start with one The olfactory bulb is it's for smell, right? It just goes up and it interfaces with the nasal cavity. Smell comes in. Great. We'll talk about that more towards the end of class, but this one is going to come up. So I guess, man, technically, I guess the olfactory is important for speech and hearing functions as well. It's actually important for eating, but that's an important part of speech and hearing functions as well. So dysphagia, right? We need to be aware of all the different components of eating. So I guess I should actually revise that previous slide. The olfactory bulb might be important for speech and hearing functions as well. Okay, so the olfactory bulb, it just carries sensory information. It brings sensory information into the brainstem. Well, this makes sense because you're not, like moving anything in your nose with the, olfactory nerve. There's nothing to move inside the nose. There's barely any muscles that can move the nose at all. I mean, some people can do it. I don't think I can. I have to move other things to move my nose. So there's no motor component at all to the olfactory nerve. What about the optic nerve? Well, it just brings in information from the eye. So it's sensory as well. Now, yes, you can move your eye around, but this nerve doesn't do anything with that. It just brings in the information. However, when we get down to the trochlear and the abducens and the ocular motor, all three of these, those are motor fibers only. Those are going to be three different cranial nerves, and they're all responsible for moving the eye. They're not responsible for bringing in any sensory information. And so they're not sensory nerves. They're just motor nerves. And that brings us to the trigeminal nerve, which this kind of makes sense, I suppose. Tri meaning three, right? And so there's three different things that it kind of works on here. So we've got the face, the sinuses, and the teeth, or you can kind of look at the way that this guy's face is portioned up here. So we've got the upper portion of the face is the first geminal, and then the middle portion of the face is the second geminal, and then the bottom portion of the face is the trigeminal. So it's kind of like this trigeminal nerve is sort of three different nerves. So there's three branches, they say, of the trigeminal nerve. The top two are sensory only. So they're going to bring in sensation from the top of the face up here, or the middle of the face. They're only bringing in sensation, just touch sensation, roof of the mouth kind of stuff, pain in the teeth. It's just bringing in that kind of sensory information. Now the bottom portion, down here in the the lower jaw portion, also has a motor component to it, and it's going to move the muscles of chewing. So we're going to talk about this cranial nerve again when we talk about chewing. This is the trigeminal nerve for chewing. And then we move to 6, which is up here, the abducens. So we talked about it already. It's another one of those eye, I was going to say muscles. It's another one of those eye-related nerves. Okay, so now we'll move to the facial nerve. Well, this makes sense again. It's facial. This is a motor nerve, so all it's doing is moving the muscles of the face. It's not taking in sensation, it's moving the muscles. All the muscles that the trigeminal nerve isn't taking care of. Most of them are taken care of by the facial nerve, and it's motor only. Why is that? Well, because the trigeminal nerve is bringing in most of the sensation from the face. So we already have that. So the facial nerve is just motor. Okay, so now we can move to, let's see, where do we want to move? Oh, we're going to jump over here. We're going to look at the intermediate nerve. Not so great. Not a good name. But I think this was discovered after they'd already been numbered. So they had to stick it in somewhere. Kind of like how the terminal nerve is not the zero nerve, it has a different name. So the intermediate the intermediate nerve is both sensory and motor. So we're looking at two of these things. And this one's a little interesting. So the motor characteristics, well, we've been talking about sensory first and all these. Let's talk about sensory first. So what is it sensing? What is it bringing into us? Well, the anterior, so the front part of the tongue and soft palate. So figure out where half your tongue is, and then the front part of that, the sensation there is governed by the intermediate nerve. Also from the soft palate, which is more towards the back of the top of your mouth. This is the sensation that this nerve is bringing to you. What does it govern motorically? Well, submaxillary and sublingual glands. These are your saliva glands down here. So like if you're a person who can gleek on command, you lift your tongue and you do something that these people do. And that is the motor portion of your intermediate nerve. Okay, so now we'll move to the next one, the vestibular cochlear nerve. This is the 8th cranial nerve, which is how a lot of people talk about it, the 8th cranial nerve. This governs audition. It also governs balance and other vestibular issues. And it's just a sensory nerve. No muscles to move in the ear. Then we get to glossopharyngeal. Oh, wait, you know what? Let's jump back up really quickly. Isn't it weird that it's just the anterior portion of the tongue that the intermediate nerve senses and not the whole tongue? Where is the rest of the tongue? It's here at the glossopharyngeal nerve. So this is going to be another motor and sensory nerve. And so let's look at sensory first, the posterior part of the tongue at the glossopharyngeal. Also the tonsils and the pharynx. Well, this makes sense. The name of it is the glossopharyngeal. So it's going to be glosso, part of the tongue, and pharyngeal. So it's going to be the back of the tongue and moving down into the pharynx. Well, that makes sense. And hypoglossal, that's also going to be part of the tongue, but it's the anterior portion of the tongue. Okay, so then the glossopharyngeal motor fibers are going to be moving the pharyngeal musculature. So all of this here with the from the nasopharynx, which is behind your nose, down to above the vocal folds, that's all pharynx. And there's a lot of muscles there that'll contract and make the pharyngeal cavity wider or narrower and contorted in different ways. That's all going to be controlled by the glossopharyngeal nerve. Okay, now the vagus nerve, it's got a lot of stuff that it takes care of. And it's kind of a mess, honestly. I mean, there's sensory fibers, there's motor fibers, but they project to different areas and different combinations, which you can see here. If you look at sensory, the ear is something governed by the vagus nerve. So just sensation on the ear. So touching the ear, blowing on the ear, anything like that, this is coming through the vagus nerve. Now remember, the actual information from the ear is coming from the 8th cranial nerve, the vestibular cochlear nerve, the stibulocochlear nerve. But sensation from the ear is coming on the vagus nerve. It also brings sensation from the trachea, and then the lungs here, the heart, the bronchi, which are down here inside the lungs, they go throughout. All those things, sensory information from all those things is part of the vagus nerve. It's kind of a catch-all. And then in terms of motor, this is going to govern things like the heart, the lungs, even the gastrointestinal tract, so the peristalsis involved in the gastrointestinal tract are governed by the vagus nerve. So it does a lot. You can think of it, Vegas, city that never sleeps. Vagus nerve also doesn't sleep because it does so much stuff. I don't know. It seems like it could help. Then we get to the accessory nerve. This is a terrible name for a nerve. It's just a motor nerve. And what it's looking at here is that it's going to move the sternocleidomastoid, which we've talked about. So here's your mastoid process back here. It comes down to your sternum. So it's a large muscle right here on the side of your neck. It's moved, it's innervated by the accessory nerve. Also the trapezius muscles, which are here on your back. Those are going to be innervated by the vagus nerve as well. And lastly, we have our hypoglossal nerve, which is another motor only. And it's going to move. This is probably going to come as no surprise because of glossal, which we've talked about already, hypoglossal, the muscles of the tongue, not the back portion of the tongue. And when I say the very back portion of the tongue, I mean down by the pharynx. So there's a portion where the tongue is going to essentially kind of become near the piriform sinuses, kind of a part of the pharynx. And so then that's going to be governed by the glossopharyngeal nerve, the motor characteristics there. Here, the hypoglossal nerve is governing pretty much all of the top part of the muscles of the tongue, things that you actually see. So what do we have that governs tongue? There's a lot of stuff, right? So we have hypoglossal, we have glossopharyngeal, and we have the intermediate. And it's broken up among all of these. The intermediate and the glossopharyngeal, between the two of them, they cover all of sensation of the tongue. And then glossopharyngeal and hypoglossal, between the two of them, they cover all of the motor characteristics for the tongue and also the pharynx. Okay, that's probably pretty confusing. That's okay. Here's a nice way to remember what's going on. So on the left, what I've got here are the first letters of all of those different nerves. And I've come up with a mnemonic device. If you think of other ones, then you definitely let me know. So I've got terse old oppressive ocarina troubadours, trip about from very good vacation accessories. Hey, you know I mean drugs. That's what the vacation accessories are. H would be hypoglossal, of course, and you know it is more than one word, but just go with hey. And this over here, I'm not really sure I like that. I mean, if you come up with a better one, then you've come up with a better one. This I do like, but I can't take credit for it. So over here on the right-hand side, this is telling us what they do. So S is a sensory nerve, M is a motor nerve, and B is both. And the mnemonic device here is some say marry money, but my brother says big brains matter more. That's a pretty easy one to remember. And it helps you know that sensory, 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 motor, motor, both, motor, both, like that. So if you can match up this mnemonic device with whatever you're using to remember terminal, olfactory, optic, oculomotor, and so on, if you can match these two up, then you know exactly that, let's say, the oculomotor is just a sensory nerve, and which ones are both. I suggest going online and looking up the most offensive mnemonic device you can find. And there are a lot for these nerves over here. It'll help you remember it. I mean, I can think of 2 or 3 different ones that these stand for, that they stand for if you find the right mnemonic device. I'm not going to say them on this video, but they definitely help me remember them just because they're so, you know, they stand out. So I'd say do that. Okay. Here's just another look at what all of these do. We talked about this, but here it is again. So if you want to look at this for your studying, it's here. And also this picture of the face is another good way to try to remember what they govern. I don't actually find it extraordinarily helpful. And want to take one quick look at some things. So we're going to skip all of that. None of that will be on the exam. Yeah, here's what I want to talk about. Okay, so this is tracing a movement from the brain to the fingertip. So we're going to start in the motor cortex right here, this green area right here. We're starting in the motor cortex. And then we're going to move down towards the basal ganglia down here in this motor loop that we have. That's going to go into the internal capsule, which is right, here, if you're following along with this kind of strand of hair. In fact, let me advance a little bit. Yeah, there we go. So you can see that these are coming down from the white matter to the internal capsule right here and going down. Then it goes to the medullary pyramid, which is right here. It's called that, again, just because of its shape. So we've gone through the internal capsule where all of these fibers come together. Those are going to come down through the pyramid, the medullary pyramid. And then there's something called the pyramidal decussation. And this is why the medullary pyramid is important. If it was just a cool structure, it wouldn't really be important. But the pyramidal decussation is important. This is where the crossover happens. So remember, the left side of the brain governs the right side of the body. And how does that switch over? Right here at the pyramidal decussation. And then it goes to the opposite side, spinal cord. So it's going to be going down. If we're looking at the left side of the brain here, it's going to go down, down, down. It's going to go through the pyramidal decussation. Then it's going to go on the right side of the spinal cord, down to the right fingertip where you make a motion. Okay, so then we can have a couple different types of lesions here. And these are things that you might see with your clients. We can have a lower motor neuron lesion, which leads to flaccid paralysis. Usually this is the cause of injury, like a car accident. Some diseases like polio leaves people with flaccid paralysis. But essentially what happens is it's damaged after it leaves that decussation, after it leaves the medulla, after it leaves the basal ganglia, somewhere in there. That's where you've got this lesion. So in the spinal cord, at any point, you can have this type of paralysis. So if you, down here where it becomes green, you're going to cut that right there. And then that's going to lead to paralysis in this guy of this leg. If you were a little bit higher, it might lead to paralysis of some of the abdominal muscles. If you were a little bit higher, it'd lead to paralysis of the arms. But flaccid paralysis. This is typically what we see with, again, like I said, injuries is this type of, and then you hear stories of someone falls and they break something, they break the spine, and then they're paralyzed. This is your typical lower motor neuron lesion. But then you can also have an upper motor neuron lesion, which is a little strange. An upper motor neuron lesion leads to an upper motor neuron response. And this kind of response can be called spastic paralysis. I mean, it kind of depends on where the injury occurs. It can do all of these different things. So it can be rigid paralysis, which is, if somebody has a paralysis where it's always like this and they can't move their hand, it's rigid, it's like stuck as a claw or something. This is rigid paralysis. This is an upper motor neuron response, something possibly in the basal ganglia or in the brainstem has been damaged. And so the background muscle tension that the basal ganglia is giving us is inhibited in some way, or actually, in the case of some of this rigid paralysis, it's overactive because you can't even move against this background muscle tension. Spastic paralysis is going to be kind of spastic movements. We've talked about some things like tardive dyskinesia, which are related to this kind of spastic paralysis. So these are uncontrollable movements. Rigid paralysis is uncontrollable too, but it's static. And then the spastic paralysis is not static. You might also have weakness. Some of the signal is still getting through, so you can move, but there's weakness. And it's not weakness because of lack of muscle tone. It's weakness because of lack of a signal getting to whatever effector you're trying to use. Poor dexterity is a similar symptom. These can be caused by stroke, traumatic brain injury, or multiple sclerosis and other hereditary disorders, cerebral palsy, for instance. Interestingly, exercise treatment is one possibility to treat upper motor neuron responses. And essentially, it's exactly what it sounds like. Work out the area that has the problem. So wherever the upper motor neuron response is causing an issue, work it out. Like do some exercise. So if you have spastic paralysis, if you do more work, so in your hand, then let's say you do strength training in the hand, that can help overcome the spastic paralysis in the hand. Of course, this doesn't work with a lower motor neuron lesion because the signal is just not getting through. So exercise treatment doesn't necessarily work there. I will end this with one cool thing, which is when I first got into graduate school, I was working with a guy who had people with stroke-induced paralysis in their hands, put their hands into a machine that would move their hand up and down for them. Some of them couldn't move at all. Some of them could. And what happened was the machine would assist them in the movement, but it didn't do it in the same way that a physical therapist does. So physical therapy, when people have this kind of paralysis, they go to physical therapy. The physical therapist moves the joint for them. And sometimes this helps, sometimes it doesn't. With the thing that we were working on where the machine moved, it was hooked up to a game. So it was like hooked up to Pong, where you have the little thing moving across, and then you need to move this thing up and hit it, and then it would go back, and then it comes back, and you have to figure out where you want to go to keep it from going off the screen. So this machine is helping these people play Pong. What's the difference between the physical therapist moving the hand and the machine moving the hand? Intent. They want to play the game. And so even if it's the machine moving for them entirely, if they have no movement whatsoever, it's still the machine moving for them, but they have the desire to move to play the game. And interestingly, we actually saw that some people made gains. So people that weren't able to qualify for help for services actually, with our procedure, did get well enough to qualify for services. So that shows that the intent of what you're doing when you have even a lower motor neuron lesion is important. You can overcome it in some way, but you have to have the intent. And that would be true for the upper motor neuron lesion as well. The more intent the person has, they are doing the workout. It's not someone just working it out for them. The quicker they'll be able to overcome the problem. So that's something that I want you to remember when you are working with your clients as well. If you're trying to get them to do some sort of facial muscular exercise, it's got to be their intent to do it. Don't move the jaw for them without intent. You might have to move the jaw for them, but give them some sort of game or some sort of goal that they want to achieve so that they can pair the intent coming down from the brain with the actual movement that they're either doing somewhat or you're even helping them with, but it's the pairing of those two that's really helping. Okay, that is pretty much it. One very last thing I want to talk about is, now that we're talking about speech and language pathways and the way that these are connected with neurons, there's one really important one to talk about, which is the superior longitudinal fasciculus, also called the arcuate fasciculus. This is a group of neurons that travel together, so kind of like a white matter pathway that are going to go between two areas in the brain. This one goes from parietal to frontal. So parietal is around here to the frontal region. We used to think it connected Broca's area to Wernicke's area. Of course, now the existence of Wernicke's area is, questionable. But there are areas near Wernicke's area that are still useful to talk about. And we do know that the arcuate fasciculus does exist. So if you're looking for it, it's this one over here, this dotted line, the arcuate fasciculus. So it goes from the auditory cortex over here. It shouldn't say parietal to frontal. This is wrong. It goes from temporal to frontal, the arcuate fasciculus, because it's over here in this temporal lobe. So it's going to move out of the temporal lobe and over to the motor strip, right here where Broca's area is. This is important because it connects language production with language monitoring. The arcuate fasciculus is likely very important for monitoring our own speech. It might be an area that's really important for stuttering because that is a speech monitoring problem. We talked about, if you've had other classes with me, that the basal ganglia might be involved because there's over monitoring of the speech process in stuttering. So it's possible that the arcuate fasciculus is maybe more robust than it should be or something like that, but it's definitely involved because it is a speech monitoring process. It can also help facilitate rapid responses to other people when you're in a conversational setting as well. So that's one of the main things you need to know. It's the thing you need to know about connections in the brain for speech and language is the arcuate fasciculus. Again, it's this dotted line one here. Now, what else is in this slideshow that we're not going to talk about in this section are all of the different neural coordination that you need to do some of our other speech functions. So breathing, but we'll talk about this in the next section. We talk about breathing. We'll talk about laryngeal control and how that is affected by different cranial nerves, different, cognitive control of the larynx. Same for the velopharynx. And these are just two extra slides. So we'll talk about those as we get to those different areas. So don't forget about your cranial nerves. They're going to come up again. Okay. I will see you on Wednesday for a review, and then there is an exam on Friday. So enjoy the rest of your holiday and happy studying.